Welcome to today's Explainer. Look, we're talking about a massive medical breakthrough in maternal health today, and the stakes, they literally couldn't be higher. Usually, when we think about childbirth, we picture this joyous, routine moment, right? But in a small yet growing number of cases, surgical delivery suddenly turns into this massive, terrifying fight for a mother's life. Today, we're unpacking a fascinating clinical journal article. It details how a brilliant surgical team in India completely re-engineered one of the absolute most dangerous operations in obstetrics. And the crazy part? They're saving lives just by flipping the order of their checklist.
Okay, let's dive right into this and look at our roadmap. First up, we'll cover a dangerous delivery complication, then the traditional surgical flaw, followed by the bladder first breakthrough. After that, we'll look at the evidence from 78 cases, and finally, wrap up with a global maternal lifesaver.
All right, let's get into Section 1, a dangerous delivery complication, severe PAS complication.
So the specific complication we're focusing on is called placenta accreta spectrum, or PAS for short. To kind of de-jargonify this for a second, just imagine the placenta is like the root system of a tree. Normally, those roots attach pretty lightly to the surface of the uterine wall, right? And they detach easily after the baby is born. But with PAS, those roots just grow way too deeply. They actually invade the muscular wall of the uterus, and in really severe cases, they punch straight through it, growing right into nearby organs like the bladder. So when a surgeon has to go in and remove a uterus in this state, which is called a cesarean hysterectomy, well, it basically sets the stage for a massive surgical crisis. Now, what's really interesting about this slide is the sheer intensity of the blood vessels here. Just a quick heads up, this is a real clinical image. Because that placenta has grown so deeply, the body creates this hyperdense, highly pressurized network of blood vessels just to feed it. Look at those thick, twisting vessels right there in the uterovesical space. That's the area tucked right between the uterus and the bladder. And honestly, this right here, this is the absolute danger zone. Because of that crazy dense vascular network we just looked at, traditional surgeries face literally life or death stakes. The primary enemy here is severe bleeding. We're talking about massive hemorrhage, ranging anywhere from 500 up to an absolutely mind-boggling 30,000 milliliters. Just to put that into perspective for you, the average human body only holds about 5,000 milliliters of blood, so that means losing up to 6 times your entire body's blood volume. It's wild. This level of bleeding leads to a desperate need for massive blood transfusions, a huge risk of bladder injuries, frequent ICU admissions, and tragically, a maternal mortality rate of 1 to 6%.
Moving on to Section 2, the traditional surgical flaw, why bleeding is severe.
Now, let's look at the standard operating procedure and why it has a critical mechanical flaw. In the traditional approach, surgeons deliver the baby first. Then they try to control the main arteries, and finally, they dissect the bladder away from the uterus super late in the game. But the bladder first approach, it flips the script entirely. These surgeons dissect the bladder and those highly dangerous blood vessels first, then they deliver the baby, and then perform the hysterectomy.
This quote, right straight from the source material, hits the nail on the head regarding this flaw. It says, the bladder flap is dissected relatively late. And honestly, that delay is exactly where everything goes wrong. Think about it. In the traditional method, the second the baby is delivered, the uterus rapidly changes shape, the placenta gets disturbed, and those massive, highly pressurized blood vessels we just talked about can literally tear in an instant. By the time the surgeon actually gets around to dissecting the bladder, the whole area is flooded with blood, completely blinding their vision and leading to accidental bladder cuts and just unimaginable hemorrhage. Which brings us to Section 3, the bladder first breakthrough, bladder first approach. So the original paper actually outlines a super rigorous 19-step clinical checklist, but we've gone ahead and distilled it into these big macro steps for you. First, the surgeons keep the bladder partially filled just so they can clearly see its edges. Then, they dissect the space between the bladder and the uterus, they carefully isolate and seal off all those abnormal blood vessels, and only after that entire area is safe and clear do they finally deliver the baby. So the crucial point here is that they are doing the dissection first, before the uterine incision is even made.
If we want to really demystify the medical jargon for a second, it helps to think of this like a giant plumbing project. Surgeons refer to this as achieving peripheral vascular control. But imagine you're replacing a broken sink in your bathroom. You wouldn't just rip the main fixture out of the wall while the water is still rushing through the pipes, right? Of course not. You'd carefully shut off the local supply lines first. Well, that's exactly what these surgeons are doing. They're shutting off the localized, fragile vessels before they disrupt the main structure, which totally prevents a catastrophic flood of bleeding.
And as you'll see here, by executing this early, super careful dissection, they completely clear the danger zone before the baby is even delivered. The surgeons are now working in a perfectly safe, controlled surgical field. By isolating and dividing these vessels early on, they drastically reduce the blood loss. It's like the chaos of the old method is just entirely replaced with this calm, methodical control.
Let's look at the data in Section 4. Evidence from 78 cases. Does it work in practice?
Check out this number, 3.8%. Out of 78 patients tracked in this study who underwent this incredibly massive high-risk surgery, only 3.8% required an ICU admission. That is literally just 3 patients out of 78. And even then, they were only in the ICU for a maximum of 24 hours. For a surgery that traditionally sends a huge chunk of its patients straight to intensive care, this number is just shockingly low.
And this brilliantly illustrates the wider success of the procedure. The sheer lack of severe complications across the board here is astonishing. We're looking at only 3 bladder injuries, only 2 site infections. And just look at that second row, 0% relaparotomy for hemorrhage. That means not a single patient had to be rushed back into surgery because of unstoppable internal bleeding. No way.
But the drop in blood loss, that is the absolute true hero metric here. Typical traditional methods often average around 4,000 milliliters of blood loss. But in this study, using the Bladder First approach, the average dropped down to just 1,563 milliliters. And what's even more incredible is that in the latter half of the study, so from 2020 to 2022, as the surgical team really perfected their skill with this specific timing, that average dropped even further to just 1,239 milliliters. That's a real game changer.
Now, we treat this clinical image with absolute scientific respect. What you're seeing is the successful removal of a uterus that was deeply invaded by the placenta, extracted completely safely without massive hemorrhage. When you look at how complex and distorted this tissue actually became, the fact that it was removed with minimal blood loss and 0 maternal deaths in this study, it represents a truly monumental victory for maternal survival.
Finally, let's wrap up with Section 5, a global maternal lifesaver, beyond the hospital.
So, why does the Bladder First approach actually change the game globally? Well, let's move to this and see how it builds, mainly because it requires 0 additional high-tech resources. Traditionally, really well-funded hospitals try to mitigate all this bleeding by using expensive, risky arterial balloon catheters placed by interventional radiologists. But this new technique, it relies entirely on surgical skill and timing. It is completely replicable by trained teams in under-resourced hospitals in developing countries. It drastically reduces the burden on local blood banks, and, crucially, it maintained absolutely fantastic neonatal outcomes, with 75 live-born neonates going home safely.
So, we're going to leave you with this final, kind of provocative thought. We so often think of medical breakthroughs as requiring, million-dollar machines or newly invented miracle drugs. But here, a super simple shift in a surgical checklist, literally just doing step 3 before step 1, is saving mothers' lives without a single extra piece of equipment. It really forces us to ask, what other traditional medical conventions across all fields of medicine should we be boldly questioning today? Thank you so much for learning with us on this explainer. Stay curious, and we'll catch you next time.